Hypertension headache. This is the most common headache in the world, experienced by an estimated 70 to 80% of people at some point in their lives. And it is the one most people are referring to when they say they simply have a headache. The pain is typically described as a dull, steady pressure, not throbbing, not sharp, that feels as though a tight band or vice is being applied around the head, usually across the forehead and into the temples or the back of the skull and neck. It tends to be bilateral, meaning it affects both sides of the head simultaneously rather than one side only. The intensity is mild to moderate in most cases, uncomfortable and distracting, but rarely severe enough to prevent normal activity. Tension headaches can last anywhere from 30 minutes to several hours, and in some people they become chronic, recurring on 15 or more days per month. The exact cause is not fully understood, but the most consistent triggers are muscular tension in the neck, shoulders, and scalp, often driven by stress, poor posture, prolonged screen use, clenching the jaw, or simply holding the head in one position for too long. Dehydration and disrupted sleep are also reliable contributors. Most tension headaches respond well to over-the-counter pain relief and rest, though chronic sufferers often find that addressing the underlying posture or stress patterns is more effective over time than reaching for medication each time one begins.
Migraine. Migraine is not simply a severe headache. It is a neurological condition with a distinct mechanism, a recognizable set of associated symptoms, and a profile of experience that separates it clearly from every other headache type. The pain itself is typically unilateral, concentrated on one side of the head, and is characterized by a pulsating or throbbing quality that worsens with physical activity and can reach a severity that makes normal function impossible. Nausea is almost universal during a migraine attack. Vomiting is common, and extreme sensitivity to light and sound means that many sufferers need to lie still in a dark, quiet room until the attack passes. Attacks can last from 4 hours to 3 days. What makes migraine further distinct is the phenomenon that precedes the headache phase in roughly a third of sufferers, the aura. Migraine aura involves neurological symptoms that typically develop over 5 to 20 minutes before the pain begins. Visual disturbances, including flickering lights, zigzag lines, or temporary blind spots, numbness or tingling in the face or hands, and in rarer cases, difficulty speaking. Migraine is significantly more prevalent in women than men, with a ratio of approximately 3 to 1, and hormonal fluctuation is one of the most consistent triggers alongside specific foods, sleep disruption, stress, and changes in weather pressure. It is estimated to affect over 1 billion people globally and is among the leading causes of disability worldwide.
Cluster headache. Cluster headaches are among the most intensely painful conditions a human being can experience, described by neurologists and by those who have them as pain that is simply beyond the scale of anything most people have encountered. They occur in cycles, clusters, during which attacks happen with striking regularity, often at the same time of day or night, sometimes multiple times daily, for weeks or months at a stretch. Each individual attack is relatively brief compared to a migraine, typically between 15 minutes and 3 hours, but the intensity is extreme. The pain is always unilateral and centered around or behind one eye, often accompanied by redness and watering of the affected eye, a drooping eyelid, nasal congestion on the same side, and in some sufferers, a restless agitation during the attack that makes lying still impossible, which is one of the characteristics that most clearly separates cluster headaches from migraines, where lying still is typically the only relief available. Cluster headaches affect men more commonly than women, at a ratio of roughly 3 to 1, which is the inverse of migraine. Between cluster periods, which can last weeks to years, sufferers may be completely headache-free. The precise mechanism is not fully understood, but involves the hypothalamus, which may explain the striking circadian regularity of the attacks. They are sometimes called suicide headaches in informal medical literature, a reference to the devastating impact of severe untreated cluster periods on quality of life.
Sinus headache. Sinus headaches are frequently self-diagnosed and significantly less commonly the actual diagnosis than most people believe. True sinus headaches arise from sinusitis, inflammation of the sinuses, typically as a result of infection, and produce a deep, dull pressure in the forehead, cheekbones, and bridge of the nose that worsens when bending forward or lying down, is accompanied by congestion, nasal discharge, and sometimes fever, and follows the anatomical location of the affected sinus cavities. The important distinction is that many headaches which feel as though they originate in the sinus area are in fact migraines. Studies have found that the majority of people who report recurrent sinus headaches actually meet the diagnostic criteria for migraine, and the facial pressure and nasal symptoms that lead people to conclude they have a sinus problem are in fact part of the migraine complex. Genuine sinus headaches caused by acute infection typically resolve when the infection clears, and treatment is directed at the underlying sinusitis rather than the headache itself. Chronic sinusitis can produce ongoing facial pressure and discomfort, but it is worth noting that this kind of persistent facial pain is one of the most consistently misattributed symptoms in headache medicine.
Caffeine withdrawal headache. The caffeine withdrawal headache is one of the most reliable and predictable headaches a person can experience, and it arrives with a specific context that makes it immediately identifiable in retrospect, even if it is not recognized in the moment. Caffeine is a vasoconstrictor. It narrows blood vessels in the brain, and regular daily consumption causes the brain to adapt by increasing the number and sensitivity of adenosine receptors over time. When caffeine intake stops or is significantly delayed, these receptors are suddenly exposed to adenosine without the usual counterbalancing effect of caffeine, and the blood vessels dilate more than normal, producing a throbbing headache that typically begins within 12 to 24 hours of the last caffeine intake. The pain is usually frontal or generalized, moderate to severe in intensity, and accompanied by fatigue, difficulty concentrating, and sometimes mild nausea. People who consume as little as 1 cup of coffee or tea daily can experience withdrawal headaches if they skip their usual intake. The most reliable treatment is caffeine itself, which is why caffeine is included in some over-the-counter headache medications. The headache is temporary. Withdrawal symptoms, including the headache, typically resolve within 2 to 9 days if caffeine is stopped completely, but for daily coffee drinkers who simply miss their morning cup, a small dose of caffeine resolves it within 30 to 60 minutes. Exertion headache. The exertion headache occurs during or immediately after physical activity, running, weightlifting, swimming, sexual activity, or any sustained physical effort that significantly raises the heart rate and increases blood pressure. The pain comes on suddenly during the activity and is typically throbbing, bilateral, and moderate to severe in intensity, lasting anywhere from 5 minutes to 48 hours. The mechanism involves the rapid dilation of blood vessels in the skull in response to increased blood flow and pressure during exertion. Primary exertion headaches, those that occur in otherwise healthy people without any underlying cause, are generally benign and more common in warm weather or at high altitude, where blood vessels are already somewhat dilated. They are more common in people who also experience migraines. The important clinical consideration with exertion headaches is ruling out secondary causes. A sudden severe headache during exercise can occasionally represent a more serious vascular event, such as a subarachnoid hemorrhage, which requires immediate medical attention. Any exertion headache that is unusually severe, occurs for the first time, or is accompanied by neurological symptoms should be evaluated medically rather than assumed to be benign.
Ice pick headache. The ice pick headache is named with complete accuracy. It presents as a sudden, brief, stabbing pain, likened almost universally by those who experience it to being jabbed with an ice pick or a sharp needle, that lasts only a few seconds, occurs without warning, and disappears as quickly as it arrived. The location varies and can shift between attacks, appearing in the temple, behind the eye, at the top of the skull, or elsewhere in the head, and there is no reliable trigger or pattern that predicts when the next stab will occur. Individual stabs may occur in isolation or in irregular series of 3 or more over a short period. The brevity of each attack means that by the time a person has registered what is happening, it has already ended. Ice pick headaches are more common in people who also experience migraines, and in the majority of cases, they are benign. The sudden pain is alarming, but not indicative of serious pathology. They are also called primary stabbing headaches in clinical terminology. The cause is not well understood. Because each attack is over in seconds, they are difficult to treat with standard pain medication, though daily preventive medications are sometimes used in people who experience them frequently enough to be significantly affected.
Thunderclap Headache. The thunderclap headache is defined by its onset rather than its specific location or character. It is a headache that reaches maximum intensity within 60 seconds of beginning, producing a pain that most people describe as the worst headache of their life. The name comes from the sensation of something suddenly going off in the head, with the abruptness and intensity of a thunderclap. The thunderclap headache is a medical emergency until proven otherwise. While it can occasionally be a primary benign phenomenon, its most important association is with subarachnoid hemorrhage, bleeding into the space surrounding the brain from a ruptured aneurysm, which presents with exactly this symptom and which is life-threatening and time-sensitive. Anyone experiencing a first-ever thunderclap headache, or a headache they describe as the worst of their life with sudden onset, should receive immediate medical evaluation. Other potential causes include cerebral venous thrombosis, hypertensive crisis, cervical artery dissection, and several other serious vascular conditions. The thunderclap headache should never be assumed to be a migraine or a tension headache on first presentation, regardless of a personal history of headaches.
Hormone headache. Hormone headaches, also called menstrual migraines when they occur specifically in relation to the menstrual cycle, arise from the fluctuations in estrogen levels that occur at predictable points across the hormonal cycle. The drop in estrogen in the days immediately before and during menstruation is the most consistent trigger, producing headaches that are often more severe, longer lasting, and more resistant to standard treatment than non-hormonal migraines in the same individual. They typically occur without aura. The hormonal dimension of headache explains in large part why migraine is so much more prevalent in women than men. The difference in prevalence is negligible before puberty and largely disappears after menopause, which points directly to reproductive hormones as a significant driver. Pregnancy produces complex effects on headache patterns. Many migraine sufferers find that their headaches improve significantly during the second and third trimester as estrogen levels stabilize at high levels, while others experience worsening. The postpartum period, when estrogen levels fall rapidly after delivery, is a common time for new or worsening headaches. Hormonal contraception also interacts with headache patterns in ways that vary significantly between individuals. Some find relief, others find that hormonal contraception worsens their migraines, and combined oral contraceptives are specifically contraindicated in women who experience migraine with aura due to an increased stroke risk.
Hypertension headache. The hypertension headache is one of the most misunderstood in common perception. Hypertension, high blood pressure, is frequently assumed to cause chronic headaches, and many people with high blood pressure attribute their regular headaches to their blood pressure. The clinical reality is more specific. Mild to moderate hypertension does not typically cause headaches in the way most people believe. The hypertension headache, as a distinct clinical entity, is associated with severely elevated blood pressure, a hypertensive crisis, where the diastolic pressure reaches 120 millimeters of mercury or above, rather than the chronically elevated but lower-grade hypertension that affects millions of people. When it does occur, the hypertensive headache is typically felt as a pulsating pain at the back of the head, often present on waking in the morning and improving as the day progresses and activity increases. It is the headache of a blood pressure emergency rather than of managed chronic hypertension. This distinction matters because people who assume their everyday headaches are caused by their blood pressure may be overlooking other treatable primary headache conditions, and the assumption can work in both directions. A genuinely hypertensive crisis producing the classic symptoms should not be assumed to be a tension headache and left untreated.
Rebound headache. The rebound headache, known clinically as medication overuse headache, is one of the most common causes of chronic daily headache and is also one of the most directly caused by the treatment of headache itself. It develops when pain relief medication is taken too frequently for headache, typically on more than 10 to 15 days per month, depending on the specific medication, and the brain adapts to the regular presence of the medication in a way that lowers the headache threshold. The result is a cycle in which the headache keeps returning, the medication keeps being taken to relieve it, and the overuse of the medication prevents the headache from ever fully resolving. Almost any headache medication can cause rebound headaches with sufficient overuse. Over-the-counter pain relievers, including ibuprofen and paracetamol, triptans used for migraine, codeine-containing products, and caffeine-based analgesics. The headache itself tends to be present most days, is often dull and diffuse, and is typically at its worst in the morning. Breaking the cycle requires withdrawal from the overused medication, which initially produces a worsening of the headache before improvement occurs over days to weeks. Rebound headache is significantly underdiagnosed because both patients and clinicians may focus on the headache itself without examining the pattern of medication use that is perpetuating it.
Cervicogenic headache. The cervicogenic headache originates not in the head itself, but in the structures of the upper cervical spine, the joints, muscles, nerves, and soft tissues of the neck, and refers pain upward into the head through specific nerve pathways. The pain typically starts in the neck or the back of the head and radiates forward to the forehead, temple, or behind the eye on one side. Movement of the neck often aggravates it, and sustained postures that load the cervical spine, looking downward at a screen for extended periods, sleeping in an awkward position, or driving long distances are common triggers. The headache is usually unilateral and does not switch sides. Cervicogenic headaches are common in people with cervical disc disease, arthritis of the upper cervical joints, or a history of neck injury, including whiplash. They are also an occupational hazard for people who spend extended periods at desks or computers with poor ergonomic setup. The treatment approach differs from primary headache disorders in that it targets the underlying cervical pathology. Physiotherapy, manual therapy, nerve blocks, and addressing postural habits are generally more effective than headache-specific medication because the source of the pain is mechanical rather than neurological. Accurate diagnosis requires distinguishing cervicogenic headache from migraine and tension headache, with which it shares some features.
Dehydration headache. The dehydration headache is one of the most preventable and fastest resolving headache types, and it operates through a mechanism that is straightforward. When the body loses more fluid than it takes in, the total blood volume decreases slightly, reducing the supply of blood and oxygen to the brain. The brain itself does not contain pain receptors, but the pain-sensitive structures surrounding it, the meninges, blood vessels, and nerves, respond to these changes by producing pain. The dehydration headache is typically felt across the forehead or as a generalized pressure across the whole head, and is often accompanied by dryness in the mouth, reduced urine output, fatigue, and difficulty concentrating. It tends to worsen when the person stands up or moves, and to improve when they are lying down. Physical activity, hot weather, alcohol consumption, and illness with fever or vomiting are the most common circumstances under which dehydration sufficient to cause headache develops. The treatment is direct, gradual rehydration with water or an electrolyte solution combined with rest. In most cases, the headache begins to improve within 30 minutes to 3 hours of adequate fluid intake. The dehydration headache is one of the most commonly experienced headaches precisely because mild dehydration is extremely common, and many people go through daily life chronically slightly dehydrated without recognizing it.